My name is Louise Pye, and I'm currently the Head of Family Engagement at the Healthcare Safety Investigation Branch, so HSIB. And that involves setting up initially our processes for how we work with patients and families, looking at our resources of how we inform patients and families of what our work is, and running our sort of day-to-day advice when we come across issues or considerations about how we can work effectively with those patients and families. So in essence, supporting our investigators to make sure that we capture the voice of patients and families well within our investigations on both our maternity and our national programmes. My background is one of policing. I was a police officer for 30 years, 28 years of which was a detective, so working within serious and complex crime investigations. And within that work, certainly in the last 20 years of my service, I specialised very much in working with families within complex crime investigations. So how we informed families of what was happening, how we got the evidence from those families. Right at the very end of my service, I was asked to deliver some training for the now HSIB organisation as a result of some work I'd done on some major incidents that had happened in the UK. So I did a bit of research, looked at what was effective to transfer from the training that we were used to within the police service and what was relevant within healthcare investigations, and was asked to do that initially still as a serving police officer. So that gave me a little bit of an insight as to the differences and what patient safety was all about, because I was very naive to it before that point. And then I was really fortunate that when I left the police service, an opportunity arose to work with the newly established HSIB to very much embed patients and families in the investigations that they were then going to be conducting. So I initially came in and set up some processes for them, and then the opportunity arose to go for a position within HSIB to carry on that work, which I'm very lucky to have done for the last 4 years. So my background, as I've mentioned, is very different, having come from the police service. What it has taught me, though, is very much the importance of speaking to all those involved in a particular incident, and that is something that's very transferable over from the police service to the investigations I'm part of now. What I was able to do through my experience within the police service is look at the quality of that and the importance of that, but really importantly, how it's done, how you navigate and assist families and patients in navigating a process that to them is probably very foreign. So how you balance the needs of the families together with the needs of the investigation. So that is very, very similar to both roles that I've now experienced. However, there are some real differences as well. The investigations that I've come from in my background were very much around blame, around accountability, around intent. The healthcare investigations clearly are not about that. It's about systems, it's about learning, and it's about processes. So real differences there, and it's really important that those differences are recognised and worked within. The other thing that I would say is that the difference within communities, the difference within families, the differences between all of us as individuals is really important to recognise. And certainly with my 30 years of policing, understanding just the varying community groups, the varying family groups, and the varying needs of those groups within any investigation, that's been a really transferable bit of knowledge that I've been able to utilise and hopefully bring forward. And then lastly, I would say, is the sensitivity of the role and how difficult it is to introduce yourself to a family that have never met you before, never want to be in the situation where they've needed to meet you, but how sensitive it is to do that in a compassionate way, but in an informative way, and also to manage expectations so that you're not setting yourself up to fail, so to speak, by promising something that can't be delivered. Within the police service, the role of working with families in serious incidents was something that was done very much on an ad hoc basis when I first became a police officer, but then it became a very professional, accredited role that developed over the latter 20 years of my service. And that's something that I'm starting to see now within the patient safety role, which is really good to see. So to build relationships with families and to build that trust, I think first and foremost, openness and honesty is absolutely crucial. Even if the message that is being delivered or the message that needs to be spoken about is difficult, it's really important that there is openness and honesty in that relationship. Confidence in the process, I think, is really important. So managing the expectations of what patient safety responses actually can and can't do is really important, so that people don't feel let down because they thought it was going to achieve something that it wouldn't. And I've mentioned a few times already about families feeling listened to. I think what's really important rather, is that not only do families feel listened to, but they feel heard. It's very easy to listen and respond in a way that says you're listening at that moment, but actually hearing that and doing something with it, I think, is really important. And I think lastly, I've talked about managing expectations, but I think what's really important is that families will have needs that sit outside of an investigation and that aren't within the parameters of what it is that someone like my role is able to do. So it's being open and it's being honest and it's being very upfront about, I can't do that for you, but what I can do is give you information that may help you, that you may want to pursue to get that support or that information elsewhere. One of the biggest and most obvious challenges that HSIB have had recently is the impact of the pandemic. One of the reasons I say that is one of the things that we were very proud to be able to do within HSIB is that when we spoke with patients and their families, we would do that face to face, as long as that's something that the family felt was appropriate and it was right to do. COVID, understandably, has curtailed our ability to do that because we need to make sure that we don't bring additional risk to the families or to our own staff in the way that we do that. So what we've had to do is adapt, like most people, to other options. The most obvious option is online. However, I mentioned earlier about the needs of different families. For some families, that's not appropriate. And I think what the COVID pandemic has shown is that there perhaps is an assumption that people have both access to digital technology and also competence in using those technologies. That's not always the case. So it's really important for us that we identify straight away whether families have that access, whether they're comfortable with that access, and what are our options if that's not appropriate. And I think in addition to that is the sensitivities of the work that we undertake and the conversations that we have with families. To do that in a remote way is really difficult, to deliver that sensitivity in a way that is received with the intent in which it's delivered. So we've adapted as best as we can, but I think for some families that's not worked. And I'm glad to say that as things are starting to have a different form of normality going forward, we're able to offer that service of meeting face to face a lot more regularly now than we were able to at the beginning. I think the role of working with patients and families is developing at some pace now, which is really welcomed. I'm particularly pleased that in the new Patient Safety Incident Response Framework, PSIRF, the new framework that has been out with early adopters but is due out in May, June of this year, that we will now be producing within that framework some introductory guidance to how to work with patients, families and indeed staff, which HSIB has been involved in writing. So I'm really glad to say that that will be some guidance that will support people, whether they're in a role of a family liaison officer, whether they're investigator, whether they're someone that's brought in for the relevant response to whatever the incident is, there will be some guidance. So that, I think, is a really good and positive step forward. There's also coming towards the end of its 3 years, the research by the Learn Together team, the Leeds Bradford research, that's also coming towards its final year, which will produce resources and a website to support people to work with patients and families and staff as well. So again, that alongside PSIRF will be a really positive change. And then I think I'm certainly seeing more family liaison type roles develop around trusts. And I think that's really welcomed. However, a word of caution that I would put to that is that they can only deal with a certain number of families. They can only deal with a certain number of responses. And actually this work crosses much wider. I've mentioned previously about reports over the years, families reporting not feeling listened to, not feeling involved, but there's never been really, outside of duty of candour and the being open guidance, there's been very limited to actually support people out about how to do it. So hopefully this introductory guidance, which will be reviewed after a year, will give people some real tips, tools and techniques to enable them to do it. And then ultimately we can start developing our competencies and our skills to do this really well. For me, outside of work, you know, I've talked previously about my role as a police officer in the past and how we looked at proving something had or hadn't happened. I think the biggest impact of this work for me outside of my job is the way I look at things. So the human factors elements, the way that I look around why people made decisions, about the environment, about processes, about designs of things, even sitting in a waiting room. While I'm sitting in a waiting room, let's say a doctor's waiting room, I will be looking around what people are doing, what's on the wall, what the processes are, and I'm thinking with a much more critical mind now about why someone is or isn't doing something based on the environment. And that for me is a real shift of having spent 3 decades looking at things in a different way. It's been really enlightening for me to think much wider. So I'm much more questioning of why people do what they do from a systems point of view than from an individual point of view now. For me, I think it's a real privilege that we can speak to families at those difficult times and we can make a difference to them, to making sure that they feel heard, they feel listened to, and actually their involvement has made change for the better. It's really heartwarming to see some of the feedback that we get from families, because often families talk about the difference it's made, in the being listened to, which I've mentioned a number of times, but also how to have someone that's guided them through a process that's really quite daunting and confusing can make such a positive difference. And the word empowering has been used a few times. The fact that our involvement with families and guiding them through the process has empowered them and given meaning to the life of whoever it is that is involved in the patient safety incident that we're looking at. So we don't always get it right, and in fact some of the feedback that we get in relation to how we can improve is really valuable to us, because they're the people that matter. The feedback we get from families really matters to look at our process.